psychiatrists, psychologists, and also homeopathy doctors who have their expertise in mental health. I would just mention our resource persons for the CME before we proceed. Dr. Madhuri Redisar. She's a consultant homeopath and psychologist and is a founder for an NGO which is working with autism and special needs community in Bangalore. The NGO is called Myth for Life. We have Dr. Jessie Joseph on board, who is consultant psychiatrist who completed her MD in psychiatry from St. John's Medical College, Bangalore. We have with us Mrs. Usha Madan, who is a psychotherapist and emotional well-being coach. Dr. Babita Jaipal, she is a consultant homeopath and head of rural projects at Myth for Life. And also we will be joined by Dr. Pragya Sharma, who is a director, Andaman Nicobar Institute of Medical Sciences, as a chief guest for CME at 11:30 during the inaugural ceremony. So it's a privilege to organize the CME on this very crucial aspect. And as homeopaths, we're considered natural counselors. So when we know about counseling, then it's only natural that we also know about psychology of our patients, but it's never too much to learn. So with that aim, to sharpen our mental counseling skills, we are organizing the CME. And on behalf of CRUH Homeopathy, I really thank all our delegates to be a part of the CME. And if I can have the first speaker now with us, Dr. Shanti Adhikari. He is officer in charge, Clinical Research Unit, Port Blair. And he's going to introduce the theme of the CME and also speak on holistic mindscape, the need of bridging the gap between mental health and homeopathic care. Please welcome Dr. Shanti Adhikari.
Hello. Thank you, madam, for invitation. A very good morning to all of you and a warm welcome to this event, Holistic Mindscape, linking mental health and homeopathic care. I also emphasize on the two phases, that is mental health and homeopathic care, and that should be linking through the holistic approach. Today's theme is linking homeopathic care with mental health. Next. What is the purpose of these presentations? I would like to proceed two reports, that is National Mental Health and Survey of India 2015-16, Prevalence Patterns and Outcome. These key findings of the report is India needs to talk about the mental illness, and every sixth Indian needs mental health help. Mental problems are in 30 to 49 age group or over 60s, and low income linked to occurrence of mental disorders, and urban population most are affected. These studies were conducted by the Bangalore, NIMANS. They conducted in 12 states across the 6 regions, northeast and south, central, northeast, south, east and west. They conducted 12 states across the 6 regions. They came out with these key findings. And next one report is October 21. Next, Lancet. A research published in the Lancet in October 2021 found 35% increase in mental health disorder in India. According to the Global Burden of Disease Study 1990 to 2070, 19.73 crore Indians, or 1 in every 7. Previous earlier report, that is 5, and then every 7, then Lancet report 2021. Though it shows the clear magnitude or burden of the mental health disease, it clearly indicates gradually increasing, and suffer from a variety of mental problems and psychiatric disorders attributed to a twofold increase in the disease in India, with the total disease burden rising from 2.5% in 1990, that 4.7% in 2017. Next. To encourage the use of homeopathy in meeting mental health needs toward time and explore its role in reducing global mental health burden. That's why I am telling burden of the magnitude of the disease, to reduce it only possible to the holistic management, holistic care or holistic approach through homeopathic medicines. Next. Meaning of the holistics, that is on believe that parts of something that is interconnected and can be explained by the reference as a whole. In medicine and in homeopathic parlance, it characterized by the treatment of the whole persons, taking into account mental and social factors rather than just symptoms of the illness. Next. What is mental health? Mental health, in who conceptualize the mental health, is a state of well-being in which the individual realize his or her own abilities, can cope with the normal stresses of life, and can work productively and fruitfully, and is able to make a contribution to his or her community. In true senses, mental health is determined by the complex interplay of the individual and social and structural stresses and vulnerabilities. Next. Mental health is not, that is this slide slow. The mental health is very important, something everyone has interesting linked to, not probably inseparable for the physicals. All of you know homeopathic doctors, their mind and body are inseparable, and on a continuum, oath making time, on counterpart is not is a weakness, shameful, all in our mind, always something negative. It is always not to the negative, it may be always positive or negative or mingled up, and every good all the time, something you can snap out or fixed or fake news. Next. The mind-body bridge. Mental disease are considered symptom manifested on the mental level as a result of derangement of the person's vital force which flows through entire body. That organon of medicines teaches these course symptoms, course meaning, and homeopathic understand the assertion. We are understand this type of assertion and thus set out of the heal both mind and body, and the same time which is definitions of the holistic seen in previous slide. Earlier I also mentioned that. Next. Glimpse of literature. Dr. Hahnemann, precursor of the psychosomatics and somatopsychiatrics, in approaching organon of medicine 2010 and 2032, Dr. Hahnemann described the mental disease, and approaching 2010, he says that in all disease being treated, the psychic conditions of the patient should be written down among his totality of symptoms as one of the most important, if one desired to have a faithful picture of the disease from which to make a successful homeopathic care. Next. Nearly 1/8 of the repertoire is dedicated to the mind books, how mind is emphasized or collecting of the mind symptoms is important, and Dr. Scales repertoire, there are 529 rubrics, mind related rubrics and sub rubrics are there. There are plenty of the rubrics in mind in Kent repertoire. Next. No misdiagnosis. Homeopathy have a clear role in mental disease because it avoids the diagnostic knots, leading to symptomatic and complete treatment of the individual. It offers a cost-effective model of conceptualization and treatment that can be integrated in people's mental health care needs. Next. Now question is, why is basing the need of the hour, and mental health prevalence, burden of the disease, and homeopathic care also holistic approach. Is there any need to bridging the need of the hour? The psychiatric disorder, the psychiatric drugs are not considered to bring about joy or permanent feeling of the wellness. Instead of it is said to just numb of the bad feelings. Otherwise, in counterpart, whereas homeopathic, the medicines go beyond just helping the persons not feeling mentally ill or out of a balance in any way, the correct remedy can bring out the two transformations in a person. I want to say this slide that psychiatric drugs is somehow balanced in the some way, but homeopathic medicine in counterpart, they holistically feeling mentally ill out of the balance in any way, and the correct remedy can be out the transformations in a person. Next. Homeopathy, with the aid of the individual specific medicines, we know remedy works to stimulate the body's natural ability to heal itself. A single careful chosen homeopathic remedy offers the help needed to restore a state of balance, health and well-being. Next. Next. A well selected, that's why a well selected remedy selected constitutionally will fit like a wetsuit to the person and not like the blanket. A constitutional medicines fit like a wetsuit to the person, just like the blanket. In various diverse clinical conditions, we treat homeopathic medicines, that is like mood disorders such as depression, anxiety, very much common in adolescents and 20 to 30 years populations, and more than 30, 40, 60, and adverse across the all age group, their prevalence of the depressions or anxiety. Its scenario has changed in the COVID and gradually increased in COVID and post-COVID scenario. Thought disorders such as OCD, paranoia and schizophrenia, personality disorder, additionally variety of emotional and mental states that are not considered as disease, including subnormals, phobias, emotional numbness and extremely reserved shy anger. Various diverse clinical conditions can be taken care too in psychiatric disease. Remember the care part of the mental health care, I bold the care. Care is not the self-care, it is the patient as a whole. We think about the care. Mental health care is more than just the treatment of the mental disorder, not. Mental health care is more than just treatment of the mental disorder. Like physical disease, we care about the physical sign and symptom, but mental disorder, just not the treatment of the mental problem or mental sign and symptom or mental ailments. According to Crane, that's why I say, sympathy and similar can go a long way in the realms of the psyche. Next. I would like to conclude in two points. In a world where the challenges to mental health are becoming increasing prevalent, it is of the paramount importance that we explore comprehensive and holistic approach to address these issues. We should adopt a holistic approach, one that considers not only physical symptoms but also the emotional and psychological aspects of the patient's conditions. Before say thank you, I read 3 sentences. Do something that makes someone happy, create something that inspires someone, and be someone's light when they are hopeless. Thank you.
Thank you so much, Dr. Adhikari. As he makes his point that homeopaths indeed can be very good psychologists and very good counselors. But of course, the theme today is that we have to bridge the gap between the mental health and homeopathy care and link the two. And for that purpose, we have with us experts from psychology and psychiatry who are going to train us on, on these aspects of mental health over the 2 days. And so I think it's not only important to manage anxiety and stress, it's also equally important to first understand what anxiety and stress is all about. And I think we had a bout of anxiety. I myself had a bout of anxiety in the morning when we were not able to start at 8. So I guess we have to kind of first appreciate that we are getting anxious, the needs for that, the reasons for that, and how to manage that. And we have expert with us, Mrs. Usha Madan, who is a psychotherapist and emotional well-being coach, MSc Genetics, MSc Psychotherapy and Counseling, consulting psychotherapist at Pramia Health, and counselor at Mitra for Life. She is a counselor coordinator at Deepika School for Special Needs Children and a resource person for Down Syndrome Federation of India. We're honored to have Mrs. Madan with us today, and we are over to her for her session, Understanding and Managing Anxiety and Stress. Over to you, please.
Good morning. If you don't respond, I get stressed out. Yeah, that's better. Yeah, today it was very overwhelming and also very heartening to listen to our previous speaker, who is from homeopathy.
Sorry, Harleen. Harleen, that's Harleen.
The speaker.
Dr. Shanti Adhikari.
Dr. Shanti Adhikari, who very clearly explained the things like the mind and body connection. So no treatment, no intervention is complete as long as it is not connected. The mind and body is not connected, and we don't use that approach. And we start treating either mind alone or the body alone with the symptoms. That is a wonderful beginning to start this session. And coming to my session of this, understanding more about stress and anxiety and why should we know that, I just want to start my session with a question. As doctors who know about mind and body, when are you going to refer your clients or the patients to a psychotherapist? That gives a clear idea about where do we stand. Are we really doing integrated interventions and a holistic approach? Or do we think, I know about it and I can do it myself alone? Neither I can do that, nor any other intervention specialist can do that. It's not wrong, but we won't be doing a complete job. That's the point I want to derive. So I hope you are all having your system, supporting system, because doctors do need supporting system to make their intervention successful, isn't it? So I hope you all have your own supportive system with ancillary therapists like yoga, meditation experts, and also psychotherapists, so that we work as a team. And it's very, very important and very interesting to know that, to be very frank, after I got an invitation for this session, I learned more about homeopathy, and now I have decided at the age of 57, I'll shift from allopathy to homeopathy. That being said, so let me start my session. So the role of psychotherapy in stress and anxiety management, and it's also called as complementing your homeopathy medication or any other medication. Next slide, please. So before we go into this, we all know that any kind of anxiety or stress is the root cause for many of our disorders or complications. There is an adage in English which says that, it is a fact, let me start with a fact. There is a fact that emotions can't be suppressed within our body. Either we facilitate the expression through our oral communication, or body takes its own way of expressing it through our pains and aches. That's a fact, we all know that. Even starting from the childhood, that is the thing. A child can't express, it develops something else. So once we are sensitive about that, if you start looking at the symptoms of the body aches, pains and ailments as something which the body or the mind is, our approach entirely different and it becomes very effective. There is an adage which says that if I ignore the whispers of the body, then I will reach a stage where I have to attend to the cries of the body, that is serious ailments. Next slide, please. So having said that, let us try to understand, previous slide please. Stress and anxiety, the definition, just a recap of that, which we all know that. Stress is, can we go to the previous slide? Yeah, anxiety is nothing but we all know that. It's a state of emotion where we do a lot of overthinking, anticipating something bad is going to happen, and we start visualizing ourselves as helpless or not being able to handle the situation with the anticipated situation, or we get overwhelmed and we feel worthless. And it is normal to happen in a day-to-day life also sometimes, but the bottom line is, the crucial point is, what is the accepted threshold level for this anxiety, okay? And this anxiety starts from a very young age, as simple as a child missing the mother. It becomes anxious. So there is no particular onset age for the anxiety development. It's part of our life and existence. Then coming to stress, stress is defined as the level of excess load on the body and the mind. When it again crosses the threshold, it leads to a lot of complications. Next slide, please. As per DSM-5, there are 13 listed anxiety and disorder syndromes, disorders, which is very scientifically analyzed and evidence-based classification. And as you go by this list, you can understand there are specific reasons for each set of anxiety disorders. One is general anxiety disorder, panic disorder, social anxiety disorder, specific phobias. Phobias are where the paranoia or the paranoid, the fear has crossed and it has become excess. We call it as phobia. Okay. Then there are specific reasons. For example, as simple as off late, the dog bites, the dogs, the street dogs have become very phobia, paranoid issue for many children and parents. So that's called where we are scared of animals, but when it crosses the practical and the realistic threshold, it becomes a phobia. Then we have agoraphobia, where we have anxiety about close or the overcrowded places where we think we can't escape from that. That is called agoraphobia. It leads to a lot of social awkwardness and challenges. And then you have OCD, which Dr. Jesse is going to talk about it in detail in the next session. And we have body dysmorphic disorder. I want to dwell on this little more because this starts usually in the teenage, where we have perceived notions about our body and how do we look in comparison with what is marketed by the beauty product companies or the social media, and we start judging ourselves as good looking, bad looking, not in shape and things like that, and this leads to lot of stress and anxiety, and this sometimes extends into adulthood also. Then we have PTSD, post-traumatic stress disorder, which is equivalent to, which is nothing but having a lot of stress and anxiety bouts after a traumatic situation. You usually find it in natural calamities victims, but one more thing I want to point out, we do find it in victims of narcissistic behavior. You all must be reading a lot of things about narcissism, which is of late gathering a lot of weightage, and this narcissistic behavior victims go through this PTSD. Then we have acute stress disorder. So the stress and anxiety, actually particularly the stress, we have two kinds of stress. One is eustress and the anxiety is mild, moderate and profound. When that level crosses the moderate or the eustress level, it becomes an acute stress disorder. Then we have adjustment disorders. When the situations or the stages in the life changes, we will get into this kind of an anxiety disorder if it is not addressed or there is no proper intervention. Then we have other specified and specified anxiety disorders, and we do have separation anxiety disorder and selective mutism. So separation anxiety disorder it is seen mostly in children, where there is this, the child or the young child is separated from the comfort of the familiar environment or the caregivers. And selective mutism is mostly seen in socially challenged people, where they're okay at home. They talk to people in an informal situation, but the moment there is a formal gathering or they have to present something, so for example, as simple as this, it's quite big, as that, they get into this selective mutism. So these are the DSM classified stress and anxiety disorder types. Next slide, please. So now let us go deep into this symptoms of stress. This will be actually giving a lot of idea during the treatment measures. We have 4 types of symptoms. One is biological, physiological, psychological, and environmental. Emotional symptoms are irritability, mood swings, feeling overwhelmed, restless, and agitation. Physical symptoms can be muscle tension, headaches, fatigue, digestive issue, and rapid heart rate and sweating. Next slide, please. Then we have cognitive symptoms wherein our feelings and thoughts will get challenged. That means we may have negative pattern of feelings, or we may feel restless and things like that, or our decision-making skills can be affected. Then planning and organization of a task can be affected. Then we have difficulty focusing, we have memory challenges, and we have overthinking and poor judgment. And associated behavior symptoms can be changes in eating habits, sleeping habits, and procrastination, going on postponing, knowing very well tomorrow is the deadline, till the 12th hour, we will go on postponing. It is kind of, we also call it as passive aggression. Sometimes when we are not in term with the things happening, we also do them, we postpone things. Or other thing maybe we are so stressed out, we don't want to handle the case, so we go on buying time, knowing very well we are almost reaching the deadline. Then we have increased use of substance. As a maladaptive defense mechanism, we get into a lot of substance and tobacco addiction. Then we do have digital addiction. These are all behavioral symptoms. When we get a client or a patient with any of these symptoms, we need to first look into the root cause, that is the underlying reason, whether it is physiological, biological, or cognitive or behavior. So the moment we address this, we can have a holistic approach and treat the client or the patient better. Then coming to symptoms of the anxiety, it's almost the same, but the expression is little difficult. It will have excessive worry with no clear reason, feeling restless and feeling overwhelmed and helpless. The physical symptoms here are muscle tension, trembling or shaking, sweating, nausea or stomach discomfort, and then we have rapid heartbeat, shortness of breath, chest pain, dizziness, and then dizziness and disturbed sleep, and of course loss of appetite. Then we have cognitive, racing and intrusive thoughts. There is no clarity of thought. One after the other will be so in a confused state. We can't take any decision, difficulty in concentrating, and also fear of losing control of the situation. Then we have catastrophic thinking, that is expecting something worst is going to happen, overgeneralization. I'm going to fail, I'm going to do this, people will laugh at me, or I will fail in my exams, overgeneralizing and it is against the realistic situation. Then avoiding social interactions. When we have anxiety, we avoid social interactions, and we have impaired social skills and panic attacks. In the end, we get into panic attacks, where a lot of physical and physiological disturbance happens. Now, contributing factors. As I said, the symptoms are also from 4 different areas, and similarly, contributing factors are also from 3 major areas like psychological, environmental, and biological. Psychological is where, let me tell one sentence each about these contributors. Psychological is where your thought process, because you know the triad of behavior, feelings, and thoughts. I think so. So thoughts generates feelings, and feelings generates behavior or the actions. The behavior is a way of communication, as I said before. So the behavior or the expression or the action is either mind-wise or body-wise. So psychological factors like, having overwhelming feelings or anticipating something bad, overgeneralizing about the limitations what a person has, or always generalizing it happened last time, so it's going to happen this time also. I'm always like this. Comparison of ourselves about with others, thinking that we are not as capable as they are them. So these are the psychological contributors which leads to stress and anxiety. Then we have biological factors, whereas it can be genetic or a personality trait. Genetic is, it's proven, there are a set of people who are predisposed to stress and anxiety, more occurrence of stress and anxiety, and personality traits. People with different personalities, usually people who have perfectionist attitude and who always have bit of insecurities, they want to pose or project that they are very perfect. Those people also get into a lot of stress and anxiety, and they develop into a lot of anxiety disorders. Then we have environmental. There are actually pages of research which talks about this environmental factors, wherein the environment during the formative stages of a child induces the stress and anxiety in children. So when I take class and sessions for parental workshop in DSFI or wherever we do it, I make it a point to tell that 50% of the stress and the anxiety in a child is given by the environment and the caregivers. Unfortunately, the irony of it, in the name of making the child, we are breaking the child. If we avoid only 2 things, comparison and overgeneralization, as simple as avoiding the word, you always do this, you are always like this. Remove that always during the growing up stages. You will see a different child in your environment. The moment you start using these sentences, let us say a very simple example, a 3-year-old child wants to serve something to the guest when the guest is at home. We are scared that it may drop the tea tray or something, and okay, then also let us assume that we gave it and then it drops it. We will say, did not I tell you that? You always drop things. So we overgeneralize one behavior aspect of a child in a given situation and go on reinforcing it. Next time, suppose the child asks for the same opportunity or the chance to allow her to interact or serve guests, we say, last time aapne kiya tha na? You did not I say? So you will drop it. So kind of in the we are so anxious to project or present our child or the home in such an environment that we start over-generalizing and over-repeating and reinforcing that. That becomes an element in the component in the child's self-awareness and self-image. As a result of that, it starts affecting its self-concept. That is one aspect. As parents or significant caregivers or as teachers, we all need to avoid the word always as much as possible if it is for a negative character. Use always only when you have to talk, encourage the child. You always do well, you always talk well, you always interact well. Use that for that in that context. That is one small example I wanted to give. Then we have comparison. Look at him, look at her. When your cousin was of this age, he is to the extent that when I was of your age, I was doing this. So please stop all this. No comparison and no over-generalization. If you stop that, we can definitely, 50% of the environmental contribution is taken care of. It is as simple as that. Next slide, please. Effect of chronic stress and anxiety, physically and physiologically. As I said, the body starts expressing all this. If anyone of you have read Louis Hay's You Can Heal Your Life book, you will know that, where if you get repeated throat infection, that means you are not expressing your feelings. If you get shoulder pain, upper shoulder pain, that means you are taking more than the burden you can manage yourself. If you have repeated stomach infection, that means you are not able to be assertive. So these are the things. Every body portion, organ area is associated with one particular thought process and emotion of our mind. So I wish we all can start gifting that book to all the people instead of these bouquets or something. It will be very useful, life-changing gift it will be. So physiologically and physically, we have direct connection between the emotions and the way body reacts or responds. And if we don't make use of our vocabulary or the verbal expression, body starts showing it through aches and pains. Then we have cognitive. As I said, we'll go to the next slide, then you'll understand it better as doctors. We know that the brain has different areas for cognitive function, like memory and decision-making skills, and also higher functioning and executive function and all that. There the body, those areas of the brain starts getting affected if there is a chronic, intense and regular, we call it as FIR, frequent, intense and recurrent anxiety and disorder if you have, then it will start affecting our cognitive processing. That means we can't make proper decisions, we can't analyze the situation, we can't plan our tasks, so our whole functioning aspect gets affected. Then, sorry again, previous slide. Then we have, of course, emotional areas where it gets affected. Mostly our IPR, our quality of life gets affected when our emotional area is affected, because we being emotional animals, beings, humans, and social beings, our whole quality of life depends on what kind of relationship we have with the environment as well as with ourselves. That is intrapersonal relationship and interpersonal relationship. So the moment I am anxious and stressed out, this starts affecting the dynamics of interpersonal and intrapersonal relationship. Either I start neglecting myself or I start overgeneralizing myself in intrapersonal relationship aspect, or I start affecting my relationship with the outside world, that is interpersonal relationship, because of my lack of emotional regulation skills, or not able to identify my own emotions, how it is triggering someone's emotions, or how their emotions are affecting my well-being. So it affects our social life. Then we have again social area where the moment I'm anxious and stressed out, my social activities, my engagement with the environment, society and my family and my workplace gets drastically affected. So we should be very careful about what kind of stress and anxiety I'm going through, and is it within the threshold of acceptable limits, that is eustress or mild anxiety, which is okay. To some extent it's okay, because sometimes it also acts as a motivating factor. But way to call it as a profound or an adverse situation, we need to be very careful about that. Next slide, please. Yeah. This, you all know that, I don't need to read, say it again and again, because as homeopaths, you know the connection between mind and the body, so let me not repeat that. Next slide, please. So cognitive symptoms, again memory loss, decision, problem solving loss, all that we have. Attention of concentration, we won't be able to make decisions because we are not paying enough attention to the things to be seen, heard or analyzed. Learning also gets affected. Yeah, coming to the learning aspect here, we stress on this very much when we take training sessions to teachers, because learning happens. First, there are 4 types of learning: emotional learning, and then physical learning, then biological learning, okay, then environmental, social learning. The first step in learning is emotional learning, which starts in the UKG, LKG level. The moment child gets challenged emotionally, gets fear, anxiety, stress, the limbic area, it gets disconnected, so the learning stops. Afterwards, how much ever remedial classes you take, how much ever repetition classes you take, the child can't connect to the subject and learn. This is the reason why many of us think math is a very difficult subject. Sorry to quote, hope there are no any maths teachers here, because somewhere we have developed a mental block for that. Emotionally, we always got scared of the subject called math. As a result of that, we always felt math is a difficult subject. So it starts affecting our perceptions and also our ideas about the subjects and the way we learn and relate to the subject. So in a preschool and primary school level, it is very, very important for the teacher to have the emotional connection first, encourage the emotional learning, and then go to other areas of teaching aspects. Then cognitive symptoms, yeah, other things, we know that, thinking skills, everything gets affected. Next slide, please. This is very important, emotional challenges. Wherever there is a stress, underlying stress and anxiety, we have negative thought process. As I said, always thinking about everything in a very negative way, not even kind of appreciating others' efforts or our own efforts, always trying to find the faults at people's efforts or contribution. So every time thinking that, particularly we find it in people who are having lot of OCD and things like that, where they have overgeneralized their limitations. So this becomes a problem. Then we have mood disorders, emotional dysregulation, that is having displaced emotions, that is somewhere I am having anger with one person, but when I interact with other person, I show my anger there. That's called as displaced emotions, and usually it happens with family members. Okay, I have something going wrong in my workplace, I don't have the assertiveness or the expressive skills or the communication skills to stop that or express that. I nod my head there, come home and start shouting at my children or spouse. That is one emotional dysregulation example. Then we have decreased self-awareness and esteem and concepts. We also have cognitive biases like, as I said, overgeneralization and catastrophizing. That is feeling that something bad is going to happen. Next slide, please. So how does it affect social challenges? There will be isolation, social isolation and withdrawal. There will be social avoidance, and there will be communication difficulties, and they have either social expressions will be deficit or excess, and then we have challenging and conflicting relationship. Next slide, please. Yeah, this is self-explanatory. As I said, it affects the various parts of the brain and its function. And next slide, please. This is how it is. So as you know that there are thalamus, which is sensory gateway, and we have hypothalamus, which regulates body functioning areas, and we have prefrontal cortex, which takes care of higher order of functioning like decision making and analysis, and we have hippocampus, which takes care of memory. When we are under stress and anxiety, all these areas gets affected. As a result of that, our whole cognitive skills, that is higher order thinking and executive functioning gets affected. As a result of, there will be a lot of disturbance in our quality of life. Next slide, please. So how do we analyze whether a person needs intervention or not? We have a lot of screening tests. These tests actually universally used and popular scientific evidence-based screening tools they are. By making use of this, we can identify whether these anxiety and stress are not disastrous disorder level it has reached. It can be just used with, dealt with preliminary round of counseling or kind of talk therapy. And sometimes with the help of these screening tests, we can also find out, does it need integrated therapy, like where we need medication, psychotherapy, and other ancillary therapies. Next slide, please. So interventions are pharmacological, as we all know that, and psychological. But many, as Dr. Shanti showed the screen, the statistics, integrated approach involving medicine, psychotherapy, and ancillary therapies like art-based therapy, yoga, meditation, and relaxation techniques have been shown to give very good results. And recurrence rate is very less because it not only addresses the issues, challenging issues at a given situation, but it kind of equips and empowers a person so that the individual need not run to a doctor or a therapist every other day. So it starts creating a lot of self-belief, self-assurance, and makes the individual more efficient to manage the challenges of life. Next slide, please. The success rate, mild, okay. So that 40% area shows only medicine alone is effective. This side it says minimum 60% and above when we use the integrated approach of psychotherapy, pharmacology, and other ancillary based therapies. Next slide, please. So now coming to this very important stage of my topic, psychotherapy process. How do we do this actually? Any idea? Anybody from the audience? You already have some idea about how does psychotherapy help, or what is the process of psychotherapy? What exactly we do there? Okay. Let me just explain what it is. Psychotherapy process starts with assessment. Either we use interview or self-questionnaire methods or screening tools to find out what is the level of anxiety and stress in an individual. Then we have psychoeducation. Before we start any intervention with the client or the individual, we need to make them understand the connection between mind and body, as we all know, and the benefit of taking psychotherapy sessions along with the medication, and also making them understand it's a normal thing to happen and it can happen to anybody. That's all. We need to just educate the patient and reassure them, make them understand it is a addressable, resolvable situation. That is what we do in psychoeducation. Then we have goal setting. The third session comes, third step is goal setting. We'll sit with the client and we'll try to set the goals, like what I need to address first, what is the next, like that. For the given situation, for the given challenge, we come up with goals in the hierarchical way. Then we need to identify the triggers. It's very, very important. The triggers are the contributors or the factors which start stress and anxiety symptoms in the person. So we identify the triggers. The triggers can be again psychological, social, or biological. Then we have suitable psychotherapy models. There are different kinds of approaches and psychotherapy models which is used based on the case study. We do that, but coming to this stress and anxiety, CBT is supposed to be very, very effective model of psychotherapy. CBT is nothing but cognitive behavior therapy. Where is cognition? My thinking and behavior, associated behavioral modifications are combined, and we use CBT. The success rate here is above 80%. Minimum 80% of stress and anxiety disorders are resolved through CBT technique. Then we have acceptance and commitment theory, wherein we make the patient understand and accept their emotions, feeling, not like good and bad. Suppose as simple as if a patient is having inferiority complex and the trigger for that is that leads to jealousy, we make the patient understand it's okay to feel jealous. When I am inadequate, I always compare myself with someone and I feel jealous. And jealousy is by emotion, by nature, emotion is just an emotion. Jealousy is just an emotion. It doesn't mean that you are a bad person or you are a good person. It is an emotion felt at that time in comparison to someone's performance, and I only need to focus on how I am going to deal with that. That makes a person acceptable or not acceptable, not as bad or good. So we need to work on these things, preconceived notions about emotions. Because in our society, in general, we always say these are good emotions, these are bad emotions. Emotions are not good or bad. The activities or the consequences associated with the emotions decides whether it is socially acceptable, socially beneficial or not. So we need to make a change in our thought process about the emotions itself in the first place before we start educating others about it. Then we do cognitive restructuring and graded exposure. We use graded exposure usually to phobias, wherein we expose the clients or the patients to different level of triggers which causes anxiety or stress in them. For example, to give a very simple example, let us say there is a person who is scared of, I had a special child student who was scared of pigeons. Phobia to the level, if the pigeon was there, he would not even enter that road. And in Bangalore, you find pigeons everywhere. So the child would not come out of the house at all. So we started with making the child see the pictures of the pigeons. I told the mother to show him the pigeon pictures, then draw the pictures, and then show the visuals related to pigeons, then collect the feathers of the pigeons and make the child touch it. So like that, different grades of exposure. In the end, it takes little time, but in the end, the child could walk without any fear. Though he did not pet, at least he could walk. So his life was not affected because of that phobia. So that is graded exposure. And then we have cognitive restructuring. That is where I start changing my thought process. Usually we all have this. Simultaneously, spontaneously, our thought process keeps running. When I am talking, I already have something going on in my mind. When you are listening to me, you have something going on. Perception. How do we perceive that? How do we analyze? And how do we judge that? It has become our conditioned behavior. So every time I have a thought process telling that I'm a failure, I always fail, I always create awkward position to myself, I'm not good at talking. So these kinds of negative thought process if I have, definitely I will get into a lot of anxiety and stress. So in this session, what do? We sit with this client and ask them to give the situations where they felt anxious and stressful, and then we ask them what were the triggers, and we make them list that, and then later on we ask them what was the thought you are carrying at that moment. And then we identify the thoughts, then you will find the pattern. Most of the time the patients will be in a negative thought process of overgeneralizing their limitations. So we make them change that. We restructure the sentence. We tell them, for example, let us say that I always mess up things at the end moment. If this is the structure, thought process if client has, instead of that we tell them, I give my best, it's a challenging situation, I do well. So at least you will only focus on the efforts rather than the outcome. Most of the times clients get into problem because they only focus on the outcome rather than appreciating their own efforts. So when we start restructuring these thoughts, a lot of things are under our control. Then we have emotional regulation skills training. It starts with self-awareness, self-concept building and communication skills, assertive skills. All that we train in emotional regulation skills. Then we have grounding and relaxation technique, wherein parallelly we'll be training the clients or the patients with a grounding exercise. For example, it is also called as 5-4-3-2-1 method, wherein the moment a client is anxious or stressed, we ask them to do this. We ask them to use their panchendriyas, that is 5 sense organs, so to bring them back to that session then and there. It is called grounding, anchoring the people or the patient with the present moment. So we ask them, 5 is use your ears and from the environment pick up 5 sounds. We tell them. So we keep all the 5 sense organs engaged at that given moment. So it has been found out that when we do that, we calm down. Then we ask them 4 things what you can see in your environment. So the diversion is more on focusing on what are the things I can see. Then the 3 things what you can touch. Then 2 things what you can smell, 1 what you can eat. So this is 5-4-3-2-1 method. When we do that, lot of grounding happens and the person is in sync with the present emotion sitting in that place. So as a result of that, they calm down, and at the same time we also teach them breathing exercises so that they will focus more on their breathing, the shallow breathing and the deep breathing and all that. It naturally calms the body and the mind of the patient. Then we have need-based life skills education and training, lifestyle coaching and things like that. Where is need-based? Mostly what we find is where there are patients with stress and anxiety, we have found, it has been observed over a period of practice, people who are not assertive, who don't have good communication skills, people who are not very sure, don't have good self-confidence and self-esteem, they get into this kind of loop of anxiety and stress. So please encourage patients, we always encourage the clients to develop good self-awareness. That is what I'm good at, what are my limitations, which are the areas I need to work, and I accept myself as I am. That is self-awareness. Not in comparison with anybody, not to match anybody's expectation. This is what I am. That is complete 100 unconditional self-acceptance. That is self-awareness technique. Then we have assertive techniques, assertive skills. Most of our time of our lives are based on what kind of relationship we have with others. So am I able to say no when I can't do anything to anybody without feeling obligated or feeling, kind of I'm going to lose them. Many a times when I sit with my clients, we come up with a list of they not having assertive skills, not able to say no, and when we go deeper into that and ask them, why do you think you can't say no? They come up with reasons like, they are elders, how can I say no to them? So that is our belief system comes in the way of our assertive skills. Then I take benefit from them. They are beneficial to me, so how can I say no to them? That is transactional. Then other thing is, I have never said no because whenever I said no, I have been reprimanded. That means past traumatic experience. Then how can I say no? What will they think of me? That is social image. So there are many reasons where people hesitate to be assertive at the cost of getting stressed out and anxious. So we need to train the clients from the beginning to be assertive, to tell no without hurting others. That means it doesn't mean that you just say no flatly to everybody, but see if you can help. Otherwise you don't need to overstretch yourself. Set the boundaries properly. That is the bottom line of it. And then we usually teach this method, which is very simple, that is called as 4A method. Whenever there is a stress and anxiety, we use these 4 A's. The first A is analyze the situation. What kind of a situation? What are the triggers? What is my behavior? What are the dominating contributors? So analyze the situation. It takes just 2 to 3 minutes, that's it. Then analyze, then you have avoid. Then you go to the avoid. Can I avoid these triggers? Can I avoid this situation? So avoid. Then if you can't avoid, if the patient says, no, I can't avoid this situation or these triggers, it can be human triggers, relationships, isn't it? So you can't avoid those relationships in your life, but they are the stress causing factors. Then we say that accept them as they are. That's the only option we have. So we bring in a bit of spiritual concept aspect also here. So we tell the patients to accept them, accept those triggers as part of my existence or life or relationship, provided you want to keep up those things in your life. Sometimes there is a choice. You can remove them. If there is no choice, there is no option, then better to accept it than to fight with it every day. So then adapt. So make your own ways, coping up mechanisms or the equations wherein you will try to adapt. Suppose a particular person, presence itself causes a lot of anxiety in your life. Try to avoid that person, meeting that person as much as possible. You can't avoid, completely you can't remove that person from your life, but you adapt so that you will not have intense conversations with them, will not have debates or discussions and argument. It will be more of, very harmonious, kind of very courteous relationship. So this is 4A method. Then we have case studies. If time permits, I want to go deep into this. Okay, so I will just tell the case study here. It is based on what are the cases I have taken. One was abusive spouse with no boundaries. There was a case which was referred to me by one of the doctors for a skin infection, repeated skin allergy, a lot of issues that person had, and she was put on antibiotics first to start with, then steroids and so many other things, but the doctor felt there was something more deeper than this. So She tried her level best, but she could not reach out to the bottom line of the triggers, so that case was referred to us. Then when we found out that the major triggers were the childhood traumas, which led into a lot of, kind of not having assertive skills and not having good self-image. On top of that, she had a family wherein the husband was very abusive. So marital counseling was required, and then she also could not set boundaries in her relationship. She would stretch herself beyond her limits to attend to the needs of the other family members. Because she was not getting satisfactory or happy, signals from her spouse, she was trying to find it in other relationship. As a result of that, many a time women end up doing this. When we miss out in something, we try to compensate in some other relationship, not even knowing to prioritize the relationship. What I have to get, where I have to get there as much as possible, instead of trying to substitute it with other things. Okay, so what method I used here was CBT, self-awareness, acceptance and commitment, approach, and communication skills. CBT is where we went to this childhood things. It was always, she came from a very big family of 35 members, having cousins, and there was always constant comparison about this lady. As a child, she was not good looking, according to some aunties, according to some uncles, she was not a very good bright student like another cousin who was in abroad. So there was constant comparison. As a result of this, this lady has a very low self-esteem. So she always never felt kind of, I'm worthy of anything. So even if she get anything out of her own merits, she would always feel she was she had a privilege of having that person who would identify her good things or something. She always gave the credit to someone else. Then we started working on that self-concept, self-awareness, and also knowing the self-worth. So changing the overgeneralized statement, I am always like that, to I am capable. Then self-awareness, then acceptance and commitment. So where did we bring in? So we made her understand that, this is what, yes, I'm doing this way, communication skills are poor and I'm not assertive. So she could accept that with evidence-based explanations, taking different situations, and she was given with the help of role modeling also. We gave her a lot of training wherein she could just simply say, I'm sorry, I can't do this, I will do it when I am free, to her family members. This much she had to say. She was not even capable of saying that. So we gave training there. Then we had communication skills, So which are the safe ways of communicating with the elders of the family or youngsters or the co-sisters or something. So we gave her a lot of communication skills training. As a result of that, her emotional stability increased. I'm not trying to say that we just cured that whatever skin issues she had. The only thing is it enhanced the clinical treatment and results of the clinical treatment. So as a result of that, emotional stability established. Added to that with the proper medication, the results were very easily achieved. So that's one case. Then we have case study. This is a bit long case, but so it was a childhood abuse. There was a sexual abuse from one of the parent, and it had led to a lot of relationship issues, trust issues, and things like that. She had a lot of migraine and other issues, bodily symptoms, and she would not accept to any boy to get settled down in the marital relationship. And later on, there was over accommodation. Again, there was a lot of wrong faulty self-analysis. She would react immediately if there was any person who was approaching her, push him away, but again regret and go back. So there was a lot of no consistency in her behavior. All that lead to a lot of social and family relationship issues. Then we used CBT, then cognitive restructuring. We also taught her grounding techniques, and then assertive skills training, and self-care. So where I make myself a priority, not as a selfish nature, but as a self-care method. And then we taught her relaxation technique. The case is still going on, but she is much, much better now. So all this clearly indicates takeaway. Next slide, please. So to sum up, all this very clearly indicates every physiological condition definitely, if it is intense and severe, definitely has some underlying stress and anxiety, and it becomes imperative for us to find out what is that. Along with any kind of medication we are giving, it is always better to take care of these psychological aspects. And when we make use of psychotherapy, it not only reduces the burden on the practitioner, but at the same time, we can dwell deep into that because there are different kind of triggers, different kind of environments, and different kind of coping up mechanism a individual has developed. So to set it right or to alter that, it helps. And then we also have, that's what. So recognize the triggers, analyze them. Is it a reality or perceived? We also have to do some fact check. Sometimes we assume, we perceive a lot of things. So the moment a client comes to you with connected stress and anxiety with some situations, we can always make them understand as a thumb rule, it was my perception or was it a reality? So make that fact check and then get into coping, find out the coping mechanism what the subject has developed, because by default we human beings or any animal for that matter develops their own coping up mechanism if we are not given a structured coping up mechanism training. And it's a very natural learning process in any living being. So we need to first find out what are the coping mechanisms of the adult and then find out which is okay to continue, which is not okay to continue, and discontinue them. In that in place of that, what are the other new coping up mechanisms we need to train the client with. So this is the summary of my talk. Thank you so much.
Thank you so much, Mrs. Madan. This has been a very, very enriching session, and I think we could all relate to it on personal levels and professional levels, what you were saying. Being working ladies and in fact working men also, we have a lot of issues that we come across that we could connect with while you were speaking. I request the organizing team to just put up a standee here like we discussed. And also we are doing the session-wise feedback. So Dr. Tanya has already posted one link for session 1 and we are posting another one for session 2. And for our YouTube viewers also, we have the link for the Google form for the feedback in the chat area. So kindly keep filling your feedbacks for each session after the session finishes. So you already have the session 2 link with you, I guess, now, Dr. Tanya? Yeah, so please help us to understand how the session went by filling the form. And Mrs. Madan is also going to be a speaker for us tomorrow as well. She's taking a session on psychology of addiction, substance and device. So we are really looking forward to that as well. And this one has been a very, very good learning source. And we are going to switch to the next speaker now, Dr. Madhuri Vedisa. She is going to be speaking on pediatric neurodevelopmental disorders, synapse to society. Dr. Madhuri Vedisa, interestingly, I've heard her before, and I'm sure perhaps you also have come across a chance to hear her. She is a dedicated homeopath who is out of her interest to work on the children of the society, done a certification in autism spectrum disorder from the University of California, Davis, and also certification in adolescent health from the University of Melbourne. And she is the founder of Formate for Life, which is an NGO working with the autism and special needs community in Bangalore. Being a homeopath herself, she connects to us in 2 ways. Like she's here to train us homeopaths on different aspects of children's development. So over to you, Dr. Madhuri Vedisa. Thank you.
Yes, good morning. Audible? Yes. So good morning. Thank you all thank you for having us here. Am I audible? Is this good? Yeah, what about now? Is this good? Yeah. Yeah, check. Good? This is good? Okay, great. So good morning. Oh, we're already ready for tea. Huh? Okay, so lovely morning here in Port Blair. I hope you're all been having a good time here. It's been amazing for us to be here, and thank you, Harleen, for having us. So we'll quickly start off with a topic which is, so I wanted to call this Synapse to Society. The way we have been working with children with pediatric neurodevelopmental disorders has been not just clinical, but also in terms of helping them as they grow to adapt into society, to integrate, and to actually find some independence for themselves, and which also helps their families, right? So yes, next slide, you can go ahead. So let's just look at what are we talking about. Pediatric neurodevelopmental disorders, according to the DSM-5, is a group of conditions with onset in the developmental period. It has disorders which typically manifest in early development, before the child enters grade school, but of course we have a lot of delayed diagnosis because of various reasons. There is difficulty in actually recognizing and diagnosing. But there are deficits that produce impairments of personal, social, academic, or occupational functioning. So this is the DSM definition of what a neurodevelopmental disorder is. Next slide. Yeah. So typically, when we look at the list, the top few that stand out to us, which we commonly see, of course, today are autism spectrum disorder, ADHD. We have the intellectual disorders, and we have specific learning disorders which are commonly seen, and the rest of them, and of course tic disorders also, which we are commonly coming across nowadays. And we have the communication disorders and others which are not as commonly seen, but are being more and more diagnosed today. When we look at the demographics in India, when we look at the numbers, interestingly, it says 1 in 8 children aged 2 to 9 years living in India today have one or the other neurodevelopmental disorder. This is actually very strange statistics. We don't expect this level of it, but what is being reported is that a lot of it goes undiagnosed, a lot of it goes unrecognized, until either they go into the education system and then the deficits are found. And sometimes we're even seeing that even a severe learning disorder is recognized by the time the child is in grade 8. It is almost about 13, 14 years, right? So there is quite a delay, but this is what it is. And when we look at what is the burden of neurodevelopmental disorders, so why is it not just a disease, but one is a disorder, and second there's a huge burden. One, if, for example, in an autism spectrum disorder, the child is very challenged, it becomes a lifelong burden for the caregiver, for the parent, right? And this has societal implications, like the way, the sort of support system that the country is going to create, what sort of support are we providing these individuals, after their, caregivers' lives, what is the support structure that we have for them, right? So there are a lot of implications which we as clinicians sometimes don't, we have a very narrow focus usually, but this is something that has very long-term implications. And with the numbers of children with autism, being diagnosed, especially with autism, the numbers are increasing. And when we look at about 20 years from now, we're looking at a huge adult population and with not enough support, right? So we are actually working towards also building this support along with our clinical work. Yeah. So coming back to the developmental phase, right? When we look at the neural basis, that is what is going on neurologically. So typically in children, there are new neural pathways being formed, there are synaptic connections as the child grows and develops, right? Now a lot of these neural pathways are also formed in the process of learning and training. Now what happens here also is that as the child grows, can we have the next slide please? Yeah, so neural connections are formed at a very fast pace when the child is younger, between 0 to about 4 to 5 years, and then slowly the process slows down, and especially by adolescence it significantly slows down. And as we know, as adults, very difficult, or compared to a child, all you have to do is pick up a new device. You pick up a new tab or a phone or an iPad, and you realize your kids or your neighbors' young children will pick it up like that, and we are having to struggle with it. So these neural pathways of learning definitely slow down, the synaptic process slows down as there is aging. So this again supports the theory of earliest intervention. So if a child can be diagnosed very early on, then we are able to improve developmental outcomes, right? So a common question that I think I face is when I say, we specialize in, neurodevelopmental disorders, or we treat autism, they'll say, oh, do you cure? We are not necessarily talking about curing. We are talking about improving developmental outcomes, and we are talking about also making sure their quality of life is much better. Okay? This is the work that we are doing. Next slide, please. Yeah. So when we look at what are the developmental milestones which indicate neurodevelopmental disorders, what is it that slows down? So one, of course, is the level of the gross motor and the fine motor skills that the child has. Language and speech development, we're looking at cognitive function, we're looking at social and emotional functioning, and also the behaviors. These are the key criteria which we look at when we are assessing a child for neurodevelopment. Next slide, please. Now, what are the factors when we look at the development of a child right from the conception through the fetal development, and then the early childhood development? We look at, there are definitely genetic and epigenetic factors. Epigenetic factors today are being recognized as something very significant. That is what happens during the course of pregnancy in terms of both the mother's physical and mental health. Mental emotional health, and this is being given a lot of priority today. There's a lot of research going into it. Now, specifically when it comes to early childhood development, we look at two things. One is the nurturing environment, that is at home. Like Mrs. Usha also mentioned, what happens at home during early childhood or with the family, these can be very, very significant emotionally, as a child grows up, but also specifically it can also, if the stress level is so high, it can also become a trigger for neurological either diseases, there can be an epilepsy that is triggered, or it can even be, it contributes to the existing neurodevelopmental issue. So if you look at it, we see a lot of cases where, say, a child who is on the spectrum goes through an extremely stressful environment at home, and they're very sensitive, so the trigger, especially a child without speech, can actually end up having a mild seizure after a situation which is extremely stressful for them. Right? So this is something that we commonly see. Can we have the next slide? Thanks. So when we look at the child as a whole, the entire holistic approach that we have, also going with the biological, biosocial, environmental model, is that one, the child being central, where the biological factors, the genetic factors, and the epigenetic factors are what will contribute to development. Then we have the family, and then we have the school and therapy centers. If a child gets the right kind of school environment, gets the right kind of therapy, is able to bond with the therapist, we definitely see so much more improvement. And also a lot of times they actually integrate very well, they can even be mainstreamed. And of course society and community. We're looking at what sort of acceptance does say the neighborhood or the extended family of this person have. All this will contribute to how the child is developing and how much improvements we can make. Next slide, please. Yeah. So this is one very interesting thing which we have also studied, and we have also done clinical studies on, and the data that we are getting is very, very interesting. So factors which influence neurodevelopment, one in terms of genetic influences. So consanguineous marriage, which of course has been very, very common in India, this is a contributing factor, but especially for GDD, which is global developmental delay, where you also tend to find more challenges in terms of motor issues along with developmental issues. And this we have not seen as much of these statistics in ASD. We have seen more of this in GDD. Now, disability in the immediate family. So when we say again a developmental disorder in the immediate family, especially in ADHD, which again could have gone undiagnosed in the parent, because when we see today, when parents report, we're going through the whole case, we usually find reports that one parent, and interestingly we see more statistics with the father, that there is very similar, there's a social disconnect, there is avoidance of responsibility, or they're not in a job, there is an addiction issue. But rather than just the addiction, we do suspect that this could have been a case of ADHD which has not been diagnosed earlier on. And of course, psychiatric conditions in the parent. These are common genetic influences. Epigenetic, definitely we see one of the leading things, of course, while we see gestational hypothyroidism, we see diabetes also contributing, and also the medication that the parent also is on at that point can contribute. But of course, twin pregnancies also. Twin pregnancies, we find that these are a vulnerable population for neurodevelopmental disorders. One of the children who's either undernourished or gets less of the nourishment that they need. And of course, what's not mentioned here in the epigenetic influences is the trauma for the mother during the pregnancy. So it could be work-related stress, but largely either a relationship stress, a family stress. These, something that is extremely emotional. We actually see very similar behaviors that the child will exhibit. However, whatever type of exhibit the mother has done of their particular stress, the child, we literally see them early in childhood exhibiting very similar behaviors. And this is also being researched now. So one of the things under emotional trauma is it could even be preconception. We have so many cases where the mother will say, the day that I conceived, our relationship broke apart, but we are still living together because of the child. Now, these are situations where you do see that the child goes through quite a struggle in terms of neurodevelopment. And again, in adopted children, it is important to understand that there will be a lag, a developmental lag, because especially in an adopted child, one, nutritionally you're questioning, what happened during the pregnancy. Second, the trauma that the mother would have gone through. Either the trauma of what type of conception, and then what did she actually go through during the pregnancy which led to, giving up the child, right? So these are things we do consider. And the thing I want to mention here is, while we have premature delivery, premature birth, as a vulnerable population for neurodevelopmental disorders, we have to, while taking the case, adjust for, so for example, if the child was born 8 weeks premature, when you're looking at developmental milestones, you have to adjust for those 8 weeks and assume that there is going to be that 2-month delay. Right, so it is not, especially early, like if you're really early intervening, if you say you get a child of say 1 year or 8 months, that time frame, it's a lot of times just the parental counseling where you're saying that there will be a delay and it has to be adjusted for the prematurity. The other thing, of course, is health events during infancy. So we have, it could be chronic recurrent infections, it could be respiratory or middle ear infections. And we do see that there are cases where there is regression of development after acute condition. So the child could have gone through a very severe acute infection, and we do see regression post this. And of course, also reactions to vaccination, there could be a regression that happens. Next slide, please. Thank you. So to quickly I'm going to just rush through this. You have all seen cases. So one is in autism spectrum disorder, we are looking at challenges in social communication and interaction, as well as restricted and repetitive behaviors. These could be associated with learning and cognitive challenges, right? And of course, in autism, because it's a spectrum, the level of challenge may vary. You might have a child where the challenges are very mild, but you could also, on the other hand, the other end of the spectrum, have a child who's absolutely nonverbal and who has extreme challenges and will end up being dependent on a caregiver for a lifetime. And ADHD, which is very common, especially today, I think in urban India, we are actually seeing that, these are increasing numbers. Also because of the kind of lifestyle change that has happened, we barely give our children the freedom to play or to, indulge in like physical very regular play anymore. It's more of we even want a 6-year-old to just sit down for 6 hours and concentrate, right? If I give you all a break right now, you'll all start jumping around, right? Or you'll at least go rush out for tea. So the thing is, when we expect our children to live up to our unrealistic expectations of what behavior is supposed to be, or what sort of sitting, how much do they need to sit and concentrate. I think a lot of urbanization itself leads to these kind of numbers that we're seeing today. And these are, interestingly, ADHD is definitely lesser in rural areas, rural India even today, because also just looking at their lifestyle, the child has the freedom to run around, has more access to a green zone. All of these are contributors. Thank you. So specific learning disorders primarily affect academic skills. A lot of these are definitely not, they are not found early. Diagnosis usually happens after there is an academic struggle, after switching a couple of schools. Only then, assessment is done and these challenges are found. But typically in these children, one is we are able to see very, very good improvements with the treatment as long as the environment can support, right? If we usually see, if the child is not in a supportive school, the parent is extremely stressed, and then so the child also ends up being extremely stressed because of this, and it is more difficult to deal with if we are not able to get good support for the child. Again, with intellectual disabilities, these are also on the rise. Is it because we are putting much more academic pressure? We have high expectations. Every child, cannot go into an IIT or cannot, be a high academic performer. Realistically, even in a place like Bangalore today, we find normal schools, like mainstream schools, which are saying we won't promote a child from, lower KG to upper KG because they're not writing 3-letter words, So, and these children are sent for remediation, they're sent, the parent is sent for counseling. These are extremely unrealistic settings and expectations for a young child. So whether the diagnosis needs to happen, or you just need to allow them the space and the time and give them the support to learn, these are the questions that we do need to be asking. Next slide, thank you. So if you look at this chart, which has a lot of data on what are the comorbidities, so typically it lists for autism, for ADHD, etc. So one of the things that we very commonly see is epilepsy, and this is usually an issue. What happens in the course of early childhood is, even if there is a high febrile event, there is a high fever with one seizure, usually it is the rule even for pediatricians is supposed to be that you don't need to put them on continuous medication, but only the febrile events need to be handled properly. But the tendency is that there are, the child is put on anti-epileptics for about a year or 2 years, even at a very young age, at the age of about 2 or 3 years. So this, even the medication is going to end up affecting development, right? So these are certain things, even mood disorders, anxiety disorders, all of these are found more in children with neurodevelopmental disorders. Next slide, please. One of the key things that we have found is, can we detect early and intervene early, right? So early detection is extremely important, but how do we do it? So we also look at screening programs at nursery schools, at Anganwadis, where we say, we run them through a developmental checklist, and then once a child is recognized, then we look at, along with treatment and therapies, we're doing surveillance to make sure that they are keeping up and we are able to keep them on track. Next, please. Thank you. Coming to the homeopathic approach, and again, because this is a capacity building session, we chose not to show cases, because all of you would have seen children, with autism, with ADHD. We're going to look at overall concepts in the homeopathic approach. So one is what are, in our case taking, how is it different from a normally developing child? So these are the areas that we typically focus on. One is communication based, the other is hyperactivity based. We look at the cognition and learning areas. We look at sensory issues and behaviors, and of course the health status and the physical generals, which is again common like it is with every child. Next slide, please. We have seen, so this is data from a clinical audit we did of about 150 cases of children on the spectrum who were treated and followed up for about 3 to 4 years. And I'm just showing you part of this data. These were the remedies that, in that percentage that were used. We typically have a single remedy constitutional approach. Next, please. So this to me is more interesting. What happened in terms of response to the homeopathic treatment was threefold. So one is there is a developmental outcome, right, where we see speech and communication, we see cognition, learning, and fine motor improvements. With, so again, these are children who are on supportive therapies if the age is progressed. But if it's a very, very early intervention, then, if the child is just 1.8 or 2 years old, then based on the case and, based on the need, we put them on the supportive therapies. The second we see is the symptomatic improvement. So we see behavioral improvements, aggression comes down, we see hyperactivity comes down. Typically, say a 9, even, of course, hyperactivity improves across the ages. Even when, say, a 9-year-old child, who's grown that tall, comes into the consultation and will climb on our table in the middle of a consultation, right? And they're trying to climb onto something else. And the parent is sitting in front of you and not even bothering because, you're so disturbed that this big child is climbing on my table and is trying to do something. It's such a disruptive environment. But the parent is just calm because this is what they face all the time, right? But these are things you will actually see significantly change by consultation 3 or 4. You'll find the child sitting in front of you, for about 20, 25 minutes in one place. And that itself is such an indicator that, symptomatic improvement has happened. Sensory issues also can reduce very significantly, and as we go on, of course, I'll explain how we work. We work with inputs from teachers, from special educators, from therapists, and even in our clinics where we sit out of special schools, we have an integrated approach. The information that the special educator, the teacher can give us about the child is extremely helpful even in prescription, even for us to really get that whole picture of the child. And of course health outcomes, where we have recurrent infections, recurrent hospitalizations for these are things we know improve, and the indicators of the arrows are that everything compounds the other. So as you see a symptomatic improvement or as you see a health outcome improvement, definitely symptomatically they're going to be better. If your frequency of infections comes down, then definitely you will see hyperactivity reduce, you will see behavioral improvements. And as this happens, you see an improvement in cognition and speech over a period of time. Next slide, please. So the other very interesting thing was that also supported by the neural connections theory, in a 0 to 8 year child, in children 0 to 8 years, we find significant developmental outcomes along with symptomatic improvement. But as the age of the child progresses, we see that developmental outcomes are extremely difficult. Also because of the way the brain is working, the plasticity does reduce. So in a, say, post 9, if you find a child without speech, it's very difficult to do anything about that, right? Bring in any improvement. You can improve a lot of other things. Communication, cognition can still be worked on. And then post 14, it is largely the hormonal situation which has taken over, and there largely we're focusing on behavioral and hyperactivity. These are the improvements we're able to bring in. Next, please. Again, relating to the same data, the timeline of response we found was that the first 2 to 3 months, this is very related. I mean, we will relate it always back to what is the expectation that a parent has out of your treatment. Right? So when a parent comes and you say, we're going to work on speech, we will also work on cognition, we will work on something else, but what is it that they are getting? So typically the first 2 to 3 months, we see health outcomes, we see health improve, we see all your physical generals, whatever you're looking at, those areas will improve, like sleep, appetite. These are the things which respond in the first few months. And then in the 3 to 6 month time frame, we found that this is 3 to 6 months after starting treatment, we found that sitting tolerance is improved, hyperactivity reduces, and behaviors start showing improvement. And speech and communication takes about 8 to 10 months, or sustained improvement only comes after that 12 months or so, right? And cognition, so where we say the teacher is coming back and reporting that things are much better now, the handwriting is improved, or even in a severely challenged child, they are sitting down, they are able to handle more complex activity. This usually happens, about a year into treatment. Thank you. So when we look at the therapeutic interventions, that is along with homeopathy that we use, so speech and language therapy are something that we provide. We have a specific focus. Interestingly, in Bangalore today, a lot of the speech therapists will say, stop talking your mother tongue to your child and speak only in English, right? But this is it is counterintuitive. Our languages, any of our Indian languages are phonetic, and today English is being taught phonetically, but all our languages are very intuitive to child, the speech development in a child. So we encourage speech therapists to work with the mother tongue of you may not, Bangalore is such a city where we have you'll have to know 25 languages to, work with children. But we encourage that even if the therapist does not understand, that the parent is involved in the process, so that, speech development can happen, or the therapy can happen more intuitively. And of course, occupational therapy, again, our focus is not just providing the therapy, but to train the parent as to how do you support the child at home in terms of an occupational therapy. We work with behavioral therapists. The other significant work we do is support and training for the parents. A parent who is going through the emotional situation of accepting the diagnosis and then still saying, we have an entire session, we take only on acceptance of the diagnosis, because acceptance does not mean that, oh, that's it, my child has no potential. You accept the diagnosis and move from there towards recognizing the potential in your child, and that is when we're able to optimize what is there. And of course, for the mother, we have an emotional support group. We have a lot of older parents who support parents of younger children, so that, that emotional connect is there. And we have we do work on what our cultural practices are in terms of child development. So I'll give you an example. You can just go to the next slide. If you remember this jhula that we used to tie, right? I think let me know when to start. Yeah. I can go on while we wait for that. Yeah. So if you look at the sari jhula, the old, I'm sure it was practiced across India, right? Which we would tie for infants, and that used to be how they slept. So that jhula you saw on the slide today is being sold in the US for $99 as autism sensory therapy. And if you look at parents today, like in Bangalore, when we meet young parents, they're saying, wait, what are you talking about? Because they have no idea. It's gone out already a couple of generations to, right now. And interestingly, while the West adopts our methodology, we have started using these flat, baby cots where there is no movement for the child and then the child is not going to sleep, right? So what is very intuitive, we've had intuitive knowledge of what a child needs for development, whether it is in terms of speech or it is in terms of, that the child needs movement, right? But today we have to read it in textbooks and readapt it. Right? So at the center, the work we do is very focused on bringing back there are a lot of things which are useful, there are things which were not useful, but the ones which were useful, we do bring back, right? Yeah. So coming to what I was talking a little while ago, we work as a team, we have a homeopathic team, we work with the parents, the therapists, we work with a lot of the specialists across Bangalore, neurologists and pediatric neurologists, developmental pediatricians, and also pediatricians who become our referral source, because really when pediatricians have a room full of children who, especially in Bangalore, it's respiratory disorders, right? So a lot of delay or certain signs of neurodevelopmental disorders will go completely unnoticed. But what they do, also because there is no treatment that can be started, typically in allopathy, to stimulate development, so they are a big source of referrals for us. And of course, we work with the special educators. So we have a practice where every child, every follow-up they comes in with a note from the educator, from the therapist, so that we keep a track of what is the change that is happening. So again, like I said, we work beyond just the clinical intervention. We've looked at living with neurodiversity. So again, neurodiversity is the word that's being used today. We don't say special needs, we don't say differently abled, but neurodiversity with the assumption that it is not normal and abnormal, but there is neurotypical and there is neurodiverse. And this is the population we work with. Next slide, please. So our focus is, one is the clinical and the treatment part, which is as the child is young, but as the child grows, we do look at rehabilitation and continuum of care. So in the early years, it is therapy, it is also parent support and training, and then as the child grows, we have support groups for adolescents, parents of adolescents, we have skill building, we have community support, and this is the work we do. Next slide, please. So Mitra for Life, which is our NGO, works on, one is the outreach and rural clinics across Bangalore, where we provide homeopathy and auxiliary therapies made more accessible. We have parent support, which is a large network. We have a network of about 2,000 families who take services and support coming very differently, not just from professionals, but from other parents, so the sense of community. We have youth empowerment programs where the skills of the particular youngster, we help them turn them into a vocation, whether it's art or music, any of these. We have social inclusion. We work with schools and colleges, creating awareness, creating advocacy. And we have an entire academy where we use our traditional music and dance forms to help the child improve even in their development, etc., and also for the very talented ones to get stages. Next, please. So in conclusion, I'm going to say, so early intervention is extremely important. If you do have a child, a young child, you're treating and there is a possibility of a developmental disorder, the screening assessment can be very easily done, and it's very important to stay focused on what support and therapy the child will need. And always a multidimensional approach will be required, whether it is keeping homeopathy as the core and providing everything else, through other people, through your network, but it does need to be provided. So basically, if we can focus on the child, next, thank you. So, next one. Yeah, this is. So as medical professionals, can we be focused on the child, not just in terms of what can I do with homeopathy, but saying what is the kind of care and support that we can provide and really help with the quality of life of this child, and also try and help the family deal with this entire thing better, right? And every child has amazing potential. That is really the basis on which we do our work. and we're a community in Bangalore trying to help with this. So again, just a note, you're all welcome to also use our resources. A lot of our resources that we have available, parent training program, etc., are online and can be used for any of your patients. So yeah, this is from us. Thank you so much.
Thank you so much, Dr. Madhuri. It's been a very, very an interactive session where you've been able to tell us what homeopathy can do and what, as health professionals, we are ought to do, to the patients who are very little in expressing, but they express through the actions that they do in the clinic itself. And I think we all need to develop that cognizance and that, that realization that as health professionals, when we are talking to patients who need this extra care, we're not only doing our duty by giving our homeopathic medicines, but going the extra mile by understanding the holistic needs that they have for this kind of a situation. And we're now opening for questions and answers, and I would also request Mrs. Madan to be here. So if you have questions, and Dr. Adhikari is, I think, running around for arrangements. So we have the speakers of the pre-T sessions for questions, and I think there are many research officers here who are already or are going to take over some psychiatry or psychology related projects. So if you have any particular questions that on the topics that have been covered so far, and you think that they relate to your projects that you're taking up, so probably now the floor is open for questions. Thank you. Yeah, so we have cordless mics here. So you can just take the mics around. You have a question? Okay, sure. Yeah. So you can, but that's okay. I think you'll be more visible then. You're right in the corner. Please take the stage. Over there. So they'll do the running around, yeah. We have one more. Cordless mic ek aur de do for the audience.
My question is where...
Ma'am, the online audience won't be able to hear. One moment, please. Yeah, thank you. Is it working? Just check.
Good morning, ma'am, and thank you for the wonderful session that we have had. My question is, where does oppositional defiance disorder fall in this entire spectrum?
Yeah, thank you. So yes, oppositional defiant disorder is being diagnosed more today. But typically we see that as the age progresses, this is a diagnosis that happens, usually by about 8 to 10 years, or especially during adolescence. Right? But again, we do question the reaction between the environment and the child, which can lead to this. So more than a diagnosis, or more than giving importance to the diagnosis, we do look at what are the resolution that can be done between the environment, like Mrs. Madan also shared earlier on. Typically with a childhood conflict at home, as they grow, you can expect that there is, it used to be that they suppress it and carry it on to adulthood, and that would become a stress anxiety. But we do see now that it can manifest in adolescence itself, right? So of course there are the extreme cases where it is extremely difficult to handle, and we do work with psychiatrists to actually deal with cases. But yes, we definitely can look at it with homeopathy, but it has to be resolved multidimensionally. Yeah.
Can I add a point here? Yeah, the ODD is more, as she said, it starts as a conduct disorder in a very young age, and it depends on the approach method used, which can become a reinforcer or kind of, it more of a power struggle. If an adult always goes on suppressing a child, not allowing the child to explain or express whatever the challenges it has in a very healthy way,
then the child suppresses that, but when it gets an opportunity, it starts doing the same behavior, showing the same behavioral pattern. So it is a behavioral pattern establishment from a very young age to the adolescence. As such, adolescents have a need for establishing their power. Their identity crisis will be there, identity establishment stages would be there. So unless the environment is proactive, healthy and reassuring, this becomes a disorder later on, which starts as a different stages of performance and behavior. It becomes a disorder later on if the environment is very, very challenging.
What role would psychotherapy have in a case in these oppositional defiance disorder conditions?
As I said, we need to find out what is the need. See, everything at the end of the day, behavior is a communication. It is nothing but a form of communication. What I can't communicate, I start showing through my behavior. So when do I communicate? I communicate when there is a need to communicate. I need to tell something. I need to relate to someone. I need to express my views or opinions or my own thoughts. So once we understand the need behind that behavior, that communication, then we try to analyze and make the client or the patient or the adolescent child, I do listen to you, I'm with you, with your thoughts. We may differ, we'll agree to disagree, but I'm ready to listen to your thoughts or the feelings. That itself wins our 50% of the battle is what I say.
Right. I think it looks like that more than the children, even the adults, even the parents, they need counseling. When we are counseling the child, the parents also need to be counseling what is to be taught and not taught in that respect. So I think we have another question from Dr. Bhuvneshwari.
Yes. It's a very informative session. So my question is, madam, for the first session, so you yourself mentioned when you homeopaths referring the case to the psychotherapy. So we are working in the National Institute at Kottayam. So we do see so many cases in that. So what actually we practice in our hospital is the case after attending to the physician. So we are prescribing medicine. Then if there is improvement, then we proceed with that. Then we assess the case. For the compliance and for teaching the parents and for the sessions, we advise. So my question is, how long should we go for this therapy along with the medicine? Can you please mention the duration or guide us how to proceed for betterment for the anxiety and stress disorders?
See, there is no fixed duration as such. It is as simple as, you start evaluating the results, outcome, what is the set goal. The nearer we are to the goal, that means that is the almost approximate, allotted duration for that. But psychotherapy definitely, it should be there as for two things. One is to bring down the intensity and the reoccurrence rates. And the second thing is, will that learning, whatever happened during the psychotherapy sessions, can the client or the patient generalize to other areas of the stress and anxiety? That means, has it empowered the patient is what we look at as psychotherapists. It can't be like for every disease, disorder or a challenge, the client should not come running to the therapist or to the doctor. So there should be an overall empowering of the client. It is very subjective, we can't fix, but minimum I can say based on whatever we are seeing, minimum 4 to 5 sessions of 1 hour each is mandatory because to get some results, because rapport building itself takes time. 1 to 2 sessions goes in that because the first thing is when we deal with feelings are very sacred and very, very precious, it is very spontaneous. So we need to create a trustful environment, safe environment for the patient to share their feelings which they would have suppressed with any other person or in any other situation. That takes minimum 2 sessions, minimum I'm telling. then after that addressing, general addressing, and then in the end specific sessions related to that particular challenge for which we are seeing the client. Minimum 5 to 6 sessions is definitely needed.
This is a wonderful session. My question is to Dr. Madhuri Vadyaswara. So myself, Dr. Devdutt Nayak. Actually, you have mentioned that you are integrating homeopathy into the psychotherapy aspects. Can you make a statement on how it brings a difference in outcome in terms of duration, in terms of developmental? So if you will not give homeopathy and alone and along with homeopathy,
Yes, thank you, sir. Okay, so in fact, this is a model we have already worked on because we work out of special schools. We consult, we have OPDs at special schools across Bangalore. And what happens there is when we go in, the child is already receiving supportive therapies and is already in the special education setup, right? And we add on homeopathy as an approach. And on the other hand, in our clinical setting, there are children who come for very early intervention where the diagnosis has not happened and none of the, obviously the interventions or any of the therapies have been started. So when we look at the difference, so both ways it works. One, if it's a very early intervention, the child has not gone into a very significant delay or we are not, see, for example, when you start a remedy, when you start a homeopathic remedy, immediately we don't add on speech therapy. We wait for about 2 months for the stimulation to happen. So say a 3-year-old where they're not even making sounds, right? There's no babbling also. So the first milestone of speech has not been achieved. There we say we wait for that first 1 or 2 months. Once you have given the remedy, you will see in the reaction that the babbling, or they'll come and say, okay, we didn't hear any sounds until now. Now there is a constant pep, 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 ma, 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 something like that, right? Then we add on speech therapy because that's the right point. Because once the stimulation has happened, then you also want auditory input. That is, you want the teaching and the, the speech communication. That teaching has to happen. So we add on therapy. At schools when we work, where the child was already on all the supportive therapies and we are adding on homeopathy, we find that the teachers or the therapists report within the first 2 to 3 months a sharp improvement in whatever therapies were already being provided, the reaction, right? The speech therapist will report that, okay, now suddenly they're picking up better, okay? The teacher will actually come and tell us to the point where they will say, with a fine motor activity, they do a threading of beads. There's a thread and they have to sit and put beads into that thread. So they will say the child was barely able to do 2 or 3. Now they're sitting up to 12 to 15 beads they will sit and do, right? So it works both ways, but it is very, very important that we add it on at the right time, the therapies, right? So it definitely, the holistic approach is required, there's no doubt about it, but there are certain situations, frankly in Bangalore it's become a very commercial thing, the therapies, right? Where speech and occupational therapy, everything is packaged and sold to the parent. So you have to continuously come for 6 months. A lot of times it's not required. If you can actually empower the parent or you train them how to do this at home, they are able to get much better results than just sending for therapy. So for us, it's a holistic.
Madam, next to this, because basically our scientists, our primary job is to undertake research. So if I need to validate this effect, so what should be my primary objective? Because rather than going theoretically, because you have practical experience, what should be my primary objective? Which outcome is sensitive to homeopathic effect? So that I can measure, ultimately I can show that outcome, and that is a sensitive marker to our effect.
Yeah, so I think this is something we struggle with as clinicians because, to get into research, you say, okay, every child is important to me. So we will not go into, doing a study where, some children are only on therapy and some are on homeopathy. Of course, it can be done because there are a lot of parents who don't want to give homeopathic medicine. So definitely that study can be done. But for us as clinicians, in our work, the child is most important in bringing out an outcome.
No,
So we're hoping that
so
you
the-
would do the research.
The question basically is what can be the measurable indicator for improvement, for clinically assessing the
Right.
before and after, if we have to do a research. So what can be the most reliable and measurable indicator?
Indicator which is sensitive to homeopathic treatment. Because if a outcome measure which is not sensitive,
Right.
I need not to find, because it may take a long time to sensitive, because 2 years, 3 years.
Right,
But there are certain markers, means measures, means mental performance
Yeah.
measure, motor.
So definitely, like
So
I
what is
mentioned.
the earliest one to sensitive or moderate one where I can at least, a trial cannot run for
Yeah.
years together.
Correct.
The sensitive ones which
Yeah.
are very near
So-
future, within a 5 months, 6 months,
Yes,
within a
yes,
year.
I got your question now, yes. So one is, like I said, I think in one of the slides I mentioned, what we see actually improves, the timeline of improvement that we had. So beyond the health indicators, we have mainly behaviors and hyperactivity, and then we have the speech and cognition, right? These are very clearly, they will improve as long as there is no very heavy genetic load. Like if we see a consanguineous marriage or like a second generation consanguineous marriage, and that is the level of challenge we're treating, those are difficult. But other than that, in all of the cases, in a young child, you will find that behaviors, hyperactivity, and speech and cognition, these in the first 6 months, you will see significant change. So
Right.
these are quite reliable.
Thank you.
markers.
Dr.
Yeah.
Renu?
Thank you.
Hello, good morning, ma'am. My question is very specific for the adolescents. As we are talking, we are going for an integrated approach for the homeopathic treatment and the CBT's treatment and the psychotherapy and the parents counseling. And side by side, we are also prescribing the conventional medicines, like we are prescribing the anxiety pills or the tranquilizers to settle up their mind, or the things are going. So how safe are these medicines for the adolescents to be taken off? Because as it is promoted in the media also, usually the adolescents are watching more the pictures, and they are saying that whenever there is an anxiety, just put up in a pill and you will be better. So that creates, I think so, an issue. Is it like that, कि whenever you have such an anxiety, maybe because of the exam phobia or any other stress, like when the childs are being compared in the school or somewhere else, so is it safe to take these medicines as and when required? How should we go about it?
So we can also take this up tomorrow. We have a session on adolescent mental health. But what I quickly want to mention here is the integration we don't do in this way, right? So it is not that if we're dealing with anxiety, then we're going to ask them to go to the psychiatrist. No, the psychiatrist is brought in only at a stage where we are absolutely not able to handle behaviors with the homeopathic medication. But typically anxiety and these things, definitely homeopathy is the first approach, along with supportive psychotherapy, counseling, parent support, all of this, right? So we are not absolutely saying that it is okay to, especially with adolescents, we are not looking at, using medication as the first go. Yeah.
So we have an entire session of 1 hour tomorrow with Dr. Madhuri on this, adolescent mental health. Quickly to Dr. Deepti and Dr. Suhana and then Dr. Swapnil, and then we close the discussion.
Okay. Thank you for the wonderful session. My question is for Madam Usha. So you mentioned about the book by Louis Hay. So I have read this and have tried to follow it as well. So to understand the patient and how are they having those complaints as well. So the challenge which I face sometimes is to explain to a layman, like in that book, the problems are listed, and alongside there are some points are given that the patient or the whoever is suffering, they have to tell them to themselves that I am strong, yeah, I am focused, I am like this. So just reading this out, or how to make them implement those things is a challenge. So any guidance about that?
The statements what you are telling are called as affirmations. So before I ask my patient to start doing affirmations, I need to tell them the science behind affirmations, okay? So in psychology, affirmations are the blueprints of my thought process. We need to establish that and make the patient understand, yes, whatever I think and I say is going to manifest. There are many literature available on that. We start with our day-to-day living, so we ask them to give some examples. As let us say that when do you get more anxious? So we start with a practical example of that and just make the client say one affirmative sentence about that. Next time when you get into that kind of a situation, you know that tomorrow guests are going to come or you have to do something else, then you start telling that in the previous day itself and see does it affect your behavior or your status, mental status or physical status. We have to provide them evidences for them to believe. We usually do that. And also we give them a lot of inputs about how our thoughts affect our behavior. So in the session only sometimes if I don't have time to deal with these kind of things, I tell them, go back to your previous situation where you were traumatized and just see how you are breathing now. So immediately we will make them understand the connection between the thought passing my mind and the way of body's reaction to that. So once or twice if you do that, in whatever way you can make the patient relate to your concept of affirmations and the effect of thought process, that means you have won the trust of the patient. From then on, you can give specific affirmations to specific problems to restructure those thoughts. It helps. Usually we ask them to do it for 21 days. We first tell them, people are very, very spectacle, you know, when they come to us, it sounds very funny for them. By just telling 3 times, I will get over this. We tell them, blindly do it. Imagine if some doctor is giving you a tablet, say swallow that. The tablet is just a chemical, but you are giving that power to that because you think it is given by a doctor, right? Not by your neighbor. Similarly, you have come to me, so you just blindly tell this for 21 days, write it down, and see the effect by yourself.
Right. Dr. Suhana?
Yeah, thank you for the nice session and informative session. My question is to Dr. Madhuri. In specific learning disorders, from your experience, how helpful is the add-on of special education as well as occupational therapy along with homeopathy? I mean, what is the kind of effect it has?
Yeah. So special education is absolutely necessary, right? So what happens is, see, when we look at the specific learning disorders in a certain way, we also say it is not just about the child having learning challenges. We have challenges teaching the child from the traditional methodology, right? Which is a very rote learning methodology, or the typical schooling system we have. Now, if this child is taught in a different way, if the teacher is equipped with certain other methodologies, and the child will actually learn very well. So this is one of the key things, because especially in SLD, if you're only going to give the remedy and you're seeing certain improvements, even then you will not find very significant change in academic outcome, because the child is stuck in the same system where there are certain expectations, and there is a certain way of studying and a certain way of reporting also. Like your answers have to be written in a certain way, but the child may actually be very skilled in other areas, right? So this is one of the key things. I mean, it has to fall in place, but it can fall in place in different ways. Like if they don't have access, let's say they're from a remote area and they don't have access to a special school or a school which can handle LD, then it can be even, what we traditionally have in India is tuition teachers, right? So tuition teachers, somebody who can empathize with the child, sit one-on-one, give attention and teach in a way that the child understands, that will also make a lot of impact. Because it is one thing for us to sit in a city which has a lot of special ed support and say that yes, it is required. But what happens when the parent is, they may be living in a remote area or, rural. So then just that one person who can teach with that certain empathy will make a difference. Yeah. And OT, I think you asked me about. Yeah. See, OT is not as relevant in SLD because it's a lot to do with functional skills which they already have. It's very academic challenges that we're looking at. So typically, special education will make a very significant difference. Yeah.
Hello, ma'am. I'm Dr. Swapnil Kamble here. Thank you for this opportunity, first of all. I'm a clinician, and this question is to Dr. Madhuri, ma'am. Ma'am, the urbanization has gone wrong. It needs to be restructured in ways. My question comes from a parent who I have seen in my OPD, and they ask a lot of questions which, as a clinician, at times I cannot answer. This specific question is this is a case of ADHD with ASD symptoms, right? And the parent asks me, at now the child is like improving with some medicines, and when I give this mobile to this child, and I could not answer that question. So your this presentation, this thing about neurodevelopment, when to introduce this gadget into the child's life, this is a very disturbing and relevant question in present times. One thing, and because there are companies which are in America, to name a few, like Facebook, they employ psychologists to restructure your brain, your thoughts. So where do we introduce this technology into the lives of our children, and where do we give this like, there are questions coming, how far this phone is to be kept while the child is sleeping, and
inside the room.
and it seems like how far measurement, 1 meter, 2 meters. There are many devices. I see a lot of change. When I was a child, in my village home, the sounds were different. Now, in the present urbanized home, this civilizational concept has gone pretty wrong, I think.
Yeah.
So,
The sounds are very different.
so your question
take that.
basically.
So my
when-
question here is, when to introduce this mobile technology into the lives of our children?
Okay.
This is the question.
Okay, so this is a very interesting question. This can become an entire session on its own. But to answer it shortly, so two things that what we advise usually, with our parents, with the families that we work with. So one, there are certain technologies, especially like apps, which can help a child learn, and even for development, for speech development, for learning stimulation, there are a lot of apps available. So two things we advise: one, use, if possible, a tab or a mobile phone without a SIM card. Okay, because there is extensive work being done today on the effects of mobile radiation on not just on neurodevelopment but across. If you look it up, there is a lot of information you will find where we are also, and we also see it in our OPDs. Like, young children, say an 8-month-old or a 1.5-year-old is already addicted to watching things on YouTube, right? Nobody's singing to the child anymore. Like, do you find mothers who sing to the child anymore? No, it is YouTube singing to the child, right? So a lot of that intuitive thing we have given up to technology, right? Artificial intelligence is a thing. Yes, we must use it intelligently, but otherwise it can take over. So usually what we say is, if you can give, also to make sure you don't give passive apps. So what are passive apps? Like gaming. You would have seen those one things like there's bursting a balloon or a bubble, or, there are a lot of these games where your brain doesn't have to work, you're just reacting. There is stimulus, you react. There's stimulus, you react. So those are very, very addictive. And like you mentioned, these are built to be addictive, right? So these, we say absolutely no. So don't give children games. You give them interactive apps, on a device without a SIM card, okay? And for very limited time. You must set an alarm for say you do 20 minutes to half an hour where a child can learn, but it must be taken away within that time frame, right? First thing. And then second thing you asked, which was where do you keep a mobile phone when the child is sleeping? Outside the room. There should be, actually this is for adults also, there is entire research being done. In fact, now in Bangalore, we have companies which work on giving you protective meshes and protective paint to protect you from mobile radiation, right? So where we say that the simplest thing you can do to protect yourself, your own brain, your sleep, your health and your child's is to leave your telephones and any gadgets outside your bedroom, especially in the night. Because, and we see this in children whom we treat with hyperactivities, etc., where we say that cut off. If there is anything which is, has a mobile communication, you have a Wi-Fi device, something that's communicating with each other, there is what we call EMF, electromagnetic frequency. So we say take that away, take that influence as away as possible, right? And this is very interesting because when we were in Dharamshala last year, and we were talking to an organization there which works with the local population of children with special needs, and we had a discussion saying, why is it that there's such a disparity, like urban diagnosis of all these neurodevelopmental disorders is going up, whereas in rural population it is still not, these are not the statistics we're seeing there. It is much better, right? It is much lower. So we had a discussion on what could be affecting. So the kind of, in an urban setup, the kind of radiation that we are exposed to, even if I switch off my phone, the next 20 people have their phones, right? And in fact, some of the work that's being done says, if you live in an apartment, even if your room can be gadget free, there's somebody living above you, somebody below you, they probably have like high-tech devices. So it is quite scary if you start reading about it. But yes, we definitely have to look into this area, and we will have to look at responsible use of technology, and also understand that we are going to the extreme of thinking my mobile is my best friend, and we sleep with it on our chest, it's beside our head, and it's radiating. We don't understand it. Like now everybody understand that pesticide is a problem, right? But mobile is my best friend. No? So that has to change.
Right. Thank you so much, Dr. Madhuri and Dr. Usha, Mrs. Usha, for the very, very valuable inputs that you've given. And interestingly, there are more questions, but I know we don't have time, but a lot of questions I think will be answered in future sessions. We have dedicated sessions on digital era, and then on adolescent mental health, and many interesting sessions coming up. But right now we need to break for tea and some pakoras before we can resume. The point is that we have to, actually include one session before we can break for inaugural ceremony, and that is a very interesting session on mindfulness and well-being for physicians, and it's going to be very, I think, very interesting for all the delegates. So let's just cooperate and be back on time for the next session, which is session 4. So it's 26 past 10 right now, and let's just all be back by 10:45. So let's all pledge that we can be back here in by 10:45, so that we can resume, and we have our inaugural ceremony at 11:30. So we are hoping that we don't have to make any changes in the session, or we don't have to shorten the session only to include the inaugural ceremony. So we'll be back by 10:45. Thank you so much. And the feedback forms, I think they're coming our way, but I request, we are opening the feedback form for the session 3 as well now. I request all the delegates online and the viewers of online and the offline delegates to please fill up the forms session-wise, so that we can take your feedbacks. Thank you.
Hello. 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 Hello.